Hi, my name's Patrick and I'm in Cairns in far north Queensland and I'm doing the failed intubation drill, which is essentially a plan should you find yourself in a position where you cannot ventilate an intubated patient, cannot intubate a non-intubated patient, or can neither intubate or ventilate. The drill is an algorithm to work through in a stepwise fashion using various techniques that considers all contingencies. Once all team members are made aware of the plan, it removes any decision making and confusion as to what to do next and reduces the chance of human error at a time that is likely to be stressful and intervention time critical. Having a plan for failed intubation is indicated for all patients whose course of treatment includes intubation. It is implemented according to where in the algorithm the attempt fails, and assuming there is a fail-safe setup prior to any attempts being made and all members of the team are appropriately briefed, there are no contraindications.
This is the QAS procedure for rapid sequence induction, and the first 3 steps in the procedure are assign roles, complete RSI checklist, and complete RSI brief. And part of that brief will be to plan for and assign roles for failed intubation. The additional information for the QAS RSI guidelines state that the team performing the RSI intubation must have a thorough understanding of the failed intubation drill. In the event of a failed intubation, the most experienced operator assumes control of the airway. If there's an absence of end-tidal CO2 sensing or inappropriate end-tidal CO2 waveform measurement, the ETT must be immediately moved and the failed intubation algorithm commenced. And if intubation is unable to be achieved within 30 seconds or 2 attempts, the failed intubation airway is to be commenced. And this is the QAS failed intubation algorithm itself.
Okay, so firstly the general setup of the patient prior to the attempt being made. Monitoring, so BP, ECG, SpO2 and end-tidal CO2 all need to be on and working. Nasal cannula at 15 litres per minute plus mask O2 on and working. IV cannula connected to fluid and running. Non-invasive blood pressure on contralateral arm and BP seen. Spare cannula in situ and a bag valve mask connected to oxygen. Okay, so the setup for the procedure itself is as it should be as you move through the algorithm. So firstly, 2 laryngoscopes, both tested, blades chosen. The ET tubes, the size that you think is most likely to work for the patient. Cuffs tested, syringe attached. 2 MP airways, 2 Goodell's, a bougie. Failing that, the alternative supraglottic airway, so in Queensland we use the LMA, again tested and syringe attached, tie, lube, tape, and then finally the surgical airway, which again in Queensland we use a size 6 tube with a scalpel and a bougie. Okay, we're happy with the setup. We're just providing some pre-oxygenation for the patient. So the plan as it stands is I'm going to make an attempt to intubate. If that fails, we're going to return to basic airway, Goodell, and either 1-person or 2-person bag valve mask operation. So if it's 2-person, I'll get you to squeeze the bag. We'll return him again to his pre-induction state, and then I'll make another attempt. We'll try and troubleshoot as we can, so perhaps some laryngeal manipulation. If we find that that second attempt doesn't work, we'll again return to a basic airway, and if that doesn't work, we're going to go to an LMA. And if we find ourselves in that position where we now can't ventilate and can't intubate, then we'll proceed straight to the surgical airway. Okay, are you happy with that plan?
Yeah, absolutely.
Okay, so I'm pretty much ready, are you?
Yep.
Alright, let's do it. Alright. Okay, scope, Q. Speak it. Okay.
You got
Grade 3 view. I might get you to provide some laryngeal manipulation. Really improve things. Okay, bougie. I can't see, but I'll get you to railroad the tube. It's fine, you can look it up.
Did you? inflated. Removing the bougie.
Thank you. Attach the bag of the mask. Okay, I've got it. Thank you. Alright, so I've got no rise and fall of the chest. It doesn't feel like the correct amount of weight on it, and the end-tidal CO2 reading is not the appropriate waveform. So this is a failed attempt, so I'm going to have to pull this, so I'll get you to deflate.
Cuff deflated.
Thank you. I'll detach that. Okay, get out. Thanks for that. Okay, I'll try one person. Yeah, I can feel air leaking, so I'm going to go to two person. Right. Okay. So that's working. So we'll say for the point of the exercise we do that for another 30 seconds and return into its pre-induction state and make another attempt. Okay.
To intubate.
To intubate.
Okay.
Alright, so let's pull that off.
Let's go.
Thank you. Okay. All grade 3D. Can you
Use
provide
the
some
bit.
laryngeal manipulation? Thank you. Doesn't improve. Okay, that hasn't improved, so thank you. Again, we're going in blind. Can I get you to railroad the size 7 tube?
Size 7 tube.
Got it.
Got the bougie.
Okay. Thank you to inflate.
Cuff inflated.
Move the bougie. Thank you. Touch. Okay. Got it. Okay. So again, we have no rise and fall of the chest, inappropriate weight on the bag, and no waveform, so that's another failed attempt. I'll get you to pull. Sorry about that. And deflate the cup.
Cuff deflated.
Thank you. And get it
Back
off,
to
please.
still.
Okay. Thank you. I'll just go straight to two person. Okay. Okay, so again, got no rise and fall of the chest and no capnography waveform, so we're going to have to proceed straight to an LMA. Okay, so let's pull it off. Alright, thank you.
Let the cuff.
Thank you.
Inflated.
Okay, can you touch? That's grand. Okay. Okay. So for the point of the exercise again, we've got no rise and fall of the chest, it doesn't feel right, and we've got no end-tidal CO2 waveform, so we're going to have to proceed straight to a surgical airway. Okay, so can you deflate?
Deflated.
Okay, pull that. Okay, so now we'll do a surgical airway.
Okay.